It's a pleasure to introduce the next generation of Grewals. I've known Sartaj for a long time. Welcome, Sartaj. And he's had a great academic career. He's trained in the prestigious RP Center and has a keen mind, very interested in academics. And looking forward to your presentation, Sartaj.
Thank you, sir. Am I audible?
Yes.
Perfect. Thank you. Thank you, Dr. Shashi, for the kind introduction. So good evening, everyone. I would like to thank AIOS and Zeiss for giving me this opportunity. Today, I will be sharing my experience on delivering optical outcomes in hard cataracts with the MyLoop. So we all come across scenarios like these in our clinical practice. Terrifying hard cataracts such as these can pose a challenge even for the most experienced surgeons. Hard cataracts can be a struggle from the very initial chop to every step of nuclear disassembly, especially with a dense, leathery posterior plate that refuses to come apart, posing a challenge in further division of the nucleus and in emulsifying those pieces. With the MyLoop, we have a device and technique that makes these hard cataracts no more challenging than our other routine cataract surgeries. Without using any ultrasound or laser energy, we can easily divide the nucleus into 2, 4, or even more pieces as we desire. The only prerequisite is that there should be adequate zonular support before the surgery. So the MyLoop is a nuclear fragmentation device that features a retractable, micro-thin, super elastic, self-expanding nitinol filament that has a 300 micron diameter. Fully expanded, it has a horizontal diameter of 10.5 millimeters and an anterior-posterior height of 5.5 millimeters, which is more than enough to engulf even the largest nuclei. Once fully retracted, the loop has a diameter of 1.5 millimeters and can be easily inserted through a 2.2 millimeter incision. Now let's talk about how to use the MyLoop. This is the recently refreshed MyLoop that has a compressible rubber sleeve at the neck of the nozzle. It is very convenient to operate with just one hand, and as can be seen here, it has a very smooth mechanism of movement. It is best to hold the MyLoop like a pen and move the slider with your index finger. The older design of the MyLoop had a black mark on the nozzle. Once you inserted the MyLoop inside the eye, the black mark had to be aligned with the incision. This was important to maintain this position as you retracted the loop. The mark served as a convenient guide, helping you align the point from where the filament expands with the center of the nucleus. With the refreshed design, the black mark has been removed, and instead you keep the rubber sleeve flush with the wound, reducing the chances of pushing the instrument too far in. This also eliminates the need to repeatedly visualize and reconfirm the position of the instrument. Next, let's talk about the most important step with the MyLoop, which is tenting up the capsule and expanding the loop and making sure you have it underneath the capsule rhexis margin. So the instrument is to be inserted with the loop oriented in the coronal plane. The edge of the capsule is gently tented up with the loop, and slowly the loop is expanded. Once the loop reaches the equator of the capsule, you gently rotate your hand clockwise, orienting the loop vertically in the sagittal plane. This particular step comes with a learning curve. This video shows my very first attempt at using the MyLoop. So after inserting the instrument, expanding the loop, and trying to rotate it clockwise, I struggled with getting the loop over and around the center of the nucleus. I even tried to use the second instrument to help nudge the nucleus to the center, but with no success. After struggling for quite some time, I noticed that the loop had not completely encompassed the nucleus, and rather it was pushing the nucleus away. I tried to expand the loop a little further, and immediately you can see the nucleus moving and comfortably resting in the center of the loop. Learning from my mistake, in the very next case, I compensated by expanding the loop completely. And as can be seen, this allowed the nucleus to, the MyLoop to easily slide around the nucleus and engage it, but the overexpansion put stress on the capsule margin and stretched it to an oval shape, as can be seen over here. So to get this step just right, it is important to start expanding the loop gently till you reach the equator, then gently rotate the instrument clockwise and keep tracking for any movement of the nucleus. If the nucleus begins to move, compensate for it by slowly further expanding the loop till you see the reflex of the loop posteriorly and the nucleus is stable. Next, visualizing and aligning the loop posteriorly. As you expand the loop and it crosses the equator and comes posterior to the nucleus, it can be easily seen as a shiny reflex. Even in dense white cataracts, the reflex is still visible. It is important to keep rotating the loop till it is vertical, as this can reduce the chances of tilting of the nucleus and increases the surety of dividing the nucleus into two equal halves. Let's now talk about the use and the importance of a second instrument to prevent the tilting of the nucleus. So using a second instrument is very helpful in these dense cataracts. It helps stabilize the nucleus as you are retracting the loop, because as the loop retracts, it tends to push up or pull up the nucleus, which can pop it out of the capsular bag. In this case, we can see that being a very hard cataract, even once we divide the nucleus, there can be some isthmus of a few fibers between the two halves. So in such a situation, you have to use the second instrument to gently dissect these fibers and free the loop from those fibers. Only then can you gently withdraw the loop out of the eye. Next, let's talk about rotating the nucleus to divide it into quadrants. After dividing the nucleus once, the pieces can rotate freely. So when you try and further divide the nucleus into quadrants, the nucleus tends to rotate along with the loop as it expands around the nucleus. It is helpful to compensate for this by under-rotating the nucleus before the second division and using the second instrument to keep the nucleus stable. In certain challenging situations, you may not be able to divide the nucleus evenly in the first go. In such situations, you can first emulsify the smaller fragment and then again use the loop to further divide the larger fragment into smaller pieces and then proceed to emulsify those pieces. The loop can be easily redeployed to divide the nucleus at any stage of the surgery, even if the piece is in the anterior chamber. So the loop can be immensely helpful in challenging situations such as this one. So here we have an 86-year-old female patient with a poorly dilating pupil, significant phacodenesis, and a very hard cataract. So I started by first placing the iris hooks to allow adequate visualization. Next, during the capsular axis, we can actually appreciate the phacodenesis. We can see the lens moving about as we try to nick the capsule and start the capsular axis. So now in such situations where zonular support is weak, but it's still fairly adequate, the loop has a very unique advantage, which is that the force of the loop, the cutting force, is applied completely centripetally. So it is not putting that force onto the zonular fibers. Normally, as we try to do a chop, we will be stretching the bag. We can be moving the bag in different directions, putting a lot of stress on the zonules. And in such cases where the zonular fibers are also already weak, we can further compromise them. So here we can very easily use the loop, divide the dense nucleus into two halves without putting much stress on the zonules. In this case, I did not go ahead and further rotate it or try to rotate it to divide into four pieces because I did not want to put more stress on the zonules. But when I went ahead and tried to chop, I realized that the piece was rotating quite freely. So I actually then came out, redeployed the loop, and divided it into four pieces. So that is the beauty with this device, that you can go back in at any time and reuse it if you wish. It is not one of those things like a chop where you have to get it perfect the first time. So you have these easy to pick up pieces. You just pick them up, emulsify them, remove them. In this case, because of the poor capsular support, I went ahead, placed a CTR, then removed the remaining pieces, implanted a lens, and it was a fairly easy surgery to perform with the help of the loop. So in my experience, the best part about the loop has been that it has made surgery in these very hard cataracts far more predictable. I myself was very hesitant the first time I used the device. I was not sure how much force would be required to retract the filament and divide the nucleus. And I remember being completely surprised when it just cut through it like a warm knife through butter. There was nearly no perceivable resistance at the time of retraction. Even though it appears quite traumatic in the video, I have never experienced a compromised capsule support in any case so far. Even some of the case series that have been published have shown that the MyLoop could easily divide the nucleus in each and every case without compromising the capsule. The major reason for this, again, is that the force is applied centripetally on the nucleus alone and not the capsule, unlike chopping, where the stretching centrifugal force is applied on the nucleus and transferred onto the back. So we also have the advantage of significantly reduced phaco energy. And now the MyLoop is my go-to tool for any kind of dense cataract that I have to perform. And I will strongly recommend all cataract surgeons to definitely give it a try.